talk a little bit about acute low back pain in primary care. I think pain is something that just every primary care doctor should be able to have a little bit of a handle on, being able to assess and know what to do. At least manage it acutely and be able to refer if they need to. And low back pain is the most common physical complaint that people will come in with. Second being neck pain. So this one is going to be primarily just on getting a good assessment of low back pain. So a lot more notes in the slides here than we're going to go over, but first thing here, let's see if we can get like that. There we go. Cool. Nice. All right. So first thing is going to be red flags of low back pain. So just keep those in mind. You know, you're going to be looking at infection, looking at constitutional signs, visceral pain referrals, neurological or upper motor neuron lesions, and looking for neurological signs. Fracture, you know, you got to consider some things like the mechanism of injury, if you have a gross deformity, personal factors, osteoporosis. Compression fractures, not necessarily a red flag, but it is going to be in that fracture category. And then malignancy, just keep it on your radar. But primarily what you're going to look at in assessing low back pain is trying to get an idea of if this is going to be an urgent or non-urgent piece. So Dr. Wheeler already went over some of that first aid assessment process that I came in at. So a couple things you want to look at: level of consciousness. You know, are they alert, verbal, painful, or unresponsive? Essentially, if they're walking into your office, they're pretty much going to fall into the non-urgent category because these are all going to be already checked off if they're bringing themselves to the clinic. But things to keep in mind: ABCDs, and then central nervous system. You're looking at if they had a spinal injury or had a neck injury, how you want to deal with that. That's going to be more on that urgent side. So if any of the positives in those categories, you're going to escalate, you're going to refer out, you're going to just monitor and stabilize. But more so in office, we're going to focus on a very focused secondary survey on their acute chief complaint. So today we're talking primarily low back pain. And the acronym I'm going to give you guys is horse piss. So, horse piss, what does it stand for? History. You got your chief complaint, you got your HPI. This is generally like what we know about, right? Old cards, PQRST. Here's where you really want to get an idea of mechanism of injury. What happened? Was there sounds or sensations that they felt? Was this just come on? Did it come on acutely? Did they do something like they bent over to pick up a piece of paper or pull weeds? Or was it that they woke up and stretched and all of a sudden they couldn't move? Previous injuries and past medical history. It's going to give you a really good idea of what's actually going on. If they've never had any sort of back pain before, okay, you're a little bit more cautious. Next, observe. Observation. Expose the area. A couple acronyms there to get an idea of inflammation or different types of injuries you're looking for. So SHARP for inflammatory or inflammation, and then DPAP-BLS is a common one we use in first grade or sports medicine to assess what sort of injuries you might be looking for. Look at the area. Generally, if there's not a gross deformity or acute trauma, you're not really going to see a whole lot. Maybe some swelling, maybe some redness. After this, you want to get into range of motion. See what they can do, right? So you got passive and active range of motion that we primarily look at in the range of motion. Now here's where I want to take a minute of really understanding what you're doing with this. Because this is part of like the subjective history, but this is also going to double into your physical exam. So active range of motion, you are testing contractile tissue. So you're testing the muscles. Can they move the muscles, right? So if you're doing a flexion movement, you are testing the anterior side of the muscles. Are they able to do that or not? And where is their pain, right? Can they extend? If there's pain with extension and with active extension, you're like, okay, is the pain coming from the muscles? You have to discern, or is it a local tissue? If there's pain with flexion, is the pain in the back or the front? If their pain isn't in the back when they flex, and they're like, oh yeah, I can do that, then we know that we're not actually testing, we're testing active range of motion, and we're testing the muscles that are contracting and pulling them forward, but we're passively moving the posterior structures. So that doubles as your range of motion assessment. And passively, we're testing the inert structures, ligaments, tendons, joint capsules. So that gives you an idea right away. One movement tells you about both sides of that joint and both pieces of that back, right? Every direction they move, or if you move them, that gives you an idea of, okay, what structure are you looking at, right? So I would recommend taking some time with if you do end up seeing a lot of pain in primary care, a lot of patients are coming to you and saying, hey, like I hurt this, what should I do? Should I get referred out, whatever? Get an idea of, okay, this joint or this region of the body, or low back pain, you know, when you are having them side bend or having them extend, or if you're, you know, bending them yourselves, what are you looking at and what's coming up positive, where their pain is, what structure you're actually looking at. So when you get through active and passive range of motion, you get into strength testing, resisted range of motion. So this is going to double check your active range of motion. So if there's pain with activating that muscle, you know, okay, maybe they did actually injure the muscle, or that muscle is a pain trigger. Second, it's going to give you insight into neurological deficits. If there is a significant deficit in strength, so they're not a 5 out of 5, if they're a 3 minus 3 plus, or a 4 minus 4 plus out of 5, that tells you, okay, there's more than just the muscle piece. If there's no pain and they're just weak, then there's a neurological piece to this low back injury. So you have to assess for that. Given all of the active range of motion, passive range of motion, and the resisted, this leads you to your palpation now. So I know we normally learn with our objective findings in med school, we were like, okay, palpate first, you know, observe, palpate, and then we go into the range of motions. With pain or injury, I often do it the other way around, because this will guide you where you want to palpate now. This is where they were having the pain with their range of motion. This is where they heard that sound. This is where they felt that pain. Now you map out the pain. Start from out to in, which is the least painful, the most painful region, and you get an idea of where their pain is actually centered around and how wide it's spread. And then you grade it. Get a scale, because this is going to be useful to talk to them with follow-ups and things like that, or use of medication. You know, if they're like, oh yeah, it was a 4 or 5, and the next day it's still a 4 or 5, and the third day it's still a 4 or 5, you're like, okay, well this is what you rated it as, but you're checking on, okay, did you decrease medication use? And then you can get a better idea of if they've actually graded that scale. Special tests. Same sort of thing with the range of motion. You know what you're testing. So again, I put a lot of notes here with a couple different names of tests, specifically the ones that I use a lot in low back pain assessment, so the lumbar spine and the sacroiliac joints. These are the ones I find most useful and the highest yield. So same thing, you want to know what you're actually assessing, and make up tests in practice if you have to. The guys that named these tests after themselves, you know, Braggarts, Lesegs, Bechterews, they were no smarter than any of us sitting here. They just happened to do a test, and they're like, aha, this is my test now. But it was like, you know, external rotation of the leg and flexion, right? So make up the test. If you can't remember the name, if you can't remember what test to do, what do you want to test? What does that joint do? What does the low back do, right? Where is that joint? Where is that ligament? Where is that muscle? Remember your anatomy, and just make up the test. So one of my favorite tests that I use all the time for assessing low back pain, specifically with somebody who has a history of maybe some traumatic injury or a history of whiplash that, you know, kind of got better and now they have an acute flare, is I use what I call the squeeze and flex. This is a very, very common thing, is a hypermobile or unstable SI joint. And they'll feel that pain really coming through that SI joint, so right through the low back, and it'll come up into mid-lumbar spine or even into the thoracic spine a little bit, and they'll also feel it down into the glute a little bit. So they're like, that's where I feel it, and they can't move, they can't flex, they can't walk properly. Simple test, grab their pelvis and squeeze, and then have them forward flex again. A hypermobile SI joint will immediately reducing pain and restriction from muscle spasm if you stabilize that joint. Right, that muscle spasm will sometimes almost completely go away while you're stabilizing that SI joint. So really useful. There's no name for this one. Nobody named it after themselves. So squeeze and flex. But these are a couple of exams that I tend to use a lot for both lumbar spine, SI joint. And then summary. Once you have some data, put it together. Figure out, okay, you know, there was passive pain on passive range of motion here, or flexion here, but active extension, right? You can have a combination of tissues that are aggravated or injured or creating pain. And then this is where you get into combining with your mechanism of injury, the severity, the acuity, and then you have a better idea of what you're actually going to diagnose with it. So here I put together a little bit of a list And this is kind of what runs through my head as I'm doing my physical exam, as I'm talking to a patient, of, okay, what's the pain generator or the pain trigger? Where is that pain coming from? Where are we testing? And what sort of diagnoses or pathologies actually fall with those? So use this list. Refer back to it. If you active range of motion was painful, assess. Is there a spasm? Was there a strain or a tear? Was there an acute high force injury where they were pulling on something, right? Do they work at a hardware store and they were pulling out a sheet of wood, and as they pulled back, they felt the big spasm, right? Okay, maybe they did actually pull a muscle too hard, pull a muscle. They have a strain, they have a tear in the muscle or the tendon. Same thing, tendons. Is it acute tendonitis? Is it chronic tendinosis? Again, we're focusing on acute pain, but ligaments. You're going to have either a tear, a sprain, or an enthesitis, more from that hypermobility. Same picture. With discs, very, very common cause of that acute low back pain that we get. There's going to be a bulge or extrusion or sequestration. How severe it is. That's going to map out your severity. Also assessing for neurological signs, right? Vertebrae, I mentioned fractures. You can have compression fractures, which essentially is if they landed really hard on their tailbone and flexed into it, or if something fell on their upper back or on their head. I've had patients come in with both. One was a boulder fell on their back when they were doing construction work at their home. Somebody decided to turn around and start throwing boulders behind them and not look behind them. So they landed on them, compression fracture. Again, that one, not necessarily a red flag. There's just not much we can do about it, but be aware of it. Facet joints. This is one that, and just in low back pain altogether, I'm going to make this note. Most of us use UpToDate and we use online databases and resources. Their low back pain, especially their acute low back pain, assessment, evaluation, and treatment pages are significantly lacking in both the diagnoses that they include and the treatment options for them, because the research is all based on what we call non-specific low back pain. So everything comes out as equivocal. Nothing really worked because it's non-specific low back pain. It's non-specific because it wasn't actually diagnosed very well in these studies. It was a disc issue and a ligament issue and a hypermobility and a hypomobility restricted joint. It's like those are two opposite things that present similarly, and you do the same treatment for it, you're going to have equivocal results. So, we all really like using these databases. I use them all the time as well. This is one page that just kind of toss aside. Yeah. And then superficial nerves, neuropraxia. This is a more and more common injury that I'm seeing. You'll get that superficial pain. Again, UpToDate likes to just write this off as a psychological or a psychosomatic piece. Not true. You can have superficial nerve injuries from nerve compression or tension, so neuropraxia, and you can have that really superficial tenderness that just, it's like you're barely touching them. They can have pain, that acute pain, it's true, it's neurogenic inflammation. You want to assess for that. So you connect the tissue to the diagnosis. You have a better idea of, okay, what were you testing? What came up positive? What sort of diagnosis might you have? And these are some of the other diagnoses that I want to roll in and put in some of the pieces of what might be associated with them. So with radiculopathy, you're going to either have a disc or a stenosis, whether it's central or foraminal. You can have ligament thickening or osteophytes in the spine. It can cause radiculopathy, right? Acute, likely going to be a disc or an acute exacerbation, right? So again, assess the patient. Are they 35 and a weightlifter? Are they 65 and they just all of a sudden started having more radiculopathy symptoms, less of that acute lower back pain, more acute radiculopathy? Now we're thinking more potentially on the stenosis side. And then the piece down there at the bottom of the slide here is probably the most important single line in the entire presentation. So many of our acute low back symptoms or presentations of conditions are just going to present as an acute muscle spasm. They're just going to be unable to move. It's going to be painful in all ranges of motion, and it's what we call a protective muscle spasm. It's a smart thing. The body is doing what it should do, right? It feels an instability or it feels an acute injury, and it stops everything from moving. It says, okay, until I figure this out, don't do anything. All right, you screwed this up already, don't do anything more, right? That's kind of what we're thinking. Neurologically, it makes sense. So what we want to do is, okay, if they can't move, if they have that severe muscle spasm, you want to get an idea of, rule out your red flags, neurological assessment, and then your history is really going to be a big piece of understanding what this is, because physical exam can get difficult with a severe acute muscle spasm. So with treatment, with acute low back pain, no more rice. Sports medicine is also going away from veganism. We're meat now. Movement, exercise, analgesia, and treatment, okay? Rest is not useful. We've seen this in the research. We've seen this in clinical practice. Rest is not useful for most acute injuries. Unless you have a fracture or a severe neurological deficit, you're ruling out your red flags, do not immobilize. Keep them in the pain-free range of motion. The range of motion that they have, use it as much as possible and continue pushing that boundary just a little bit. Even if it's an acute sprain, unless it's a third-degree sprain, that's different, that needs immobilization. Complete rupture, or a fracture, that's a non-unit or displaced. You want them moving. We need to get them moving because that's the only thing that's really going to maintain that range of motion. It's going to prevent that pain turning into a chronic issue, and we're also going to get some lymphatic drainage. Exercise. Begin strengthening right away. Again, if there's no red flags, you've ruled those out, no fracture, no third-degree sprain, start strengthening right away. Again, this is going to have a direct inhibition of pain pathways immediately, of acute and chronic pain pathways. And this can start to decrease their pain immediately. So figure out what, if you can figure out, if their SI joint is unstable, and you were like, yeah, if I squeeze and their pain goes away when they're moving around, oh, that muscle spasm calms down, stabilize that SI joint, right? For those, if you do physical medicine, do some SOT blocking. If you don't, refer them to somebody who does that. Simple thing, really quick. If they have a super, super unstable SI joint, get them to do squats right away. Hold their pelvis, tape it, put an SI belt on, get them to start doing squats. That SI joint will normalize on its own. We all know how to do squats if we just start moving. The more squats you do, the better you get at it. Unstable SI joint, squats. That sacrum gets driven into that pelvis, and you just tighten. So many of my patients have come in saying, I need prolotherapy, I've been told I need this, I have a hypermobile joint. Get them doing squats and some core stability and no injections. They don't need them. The opposite is if this SI joint is really stuck, like we learned in our manip classes, right? We want to do a manipulation. You come in week after week and you have to manipulate them. Lunges. You switch it up. Lunges will rotate that pelvis, right? We know that SI joint has that rotation. Find which way it's rotated. Get them to do lunges. Keep doing the lunges. They get better at lunges. Their SI joint moves better. Don't have to do adjustments anymore. Analgesia. Now this can be whatever you need to calm down the pain. You can use ice in that first 24, 48 hours. You can do contrast, supplements, herbs, pharmacotherapy if we need to. And Dr. Wheeler mentioned Toradol. I'm going to talk about that in a second here because it's been super useful in practice. And then treatment. Start treatment as soon as possible. Consider your tissue type. Was it a soft tissue injury? Was it an osseous injury? Joint? Was it disc? Right? If they do have a history of a disc injury and it is behaving like a disc, so you did your orthopedic exams like we went over, straight leg raise or Beck-Drew slump test, and they have that radicular pain, right? Start right away. Traction, heat, and hydration are your best friends right away. Traction, heat, hydration. And then what I call directional decompression. You guys remember how discs work? It's a balloon, right, in between the vertebrae. Very, very common source of pain and irritation of the nerves in the low back. If they have what's one of the 95% of common disc herniation directions, which is posterior lateral, if it's that common presentation, all you need them to do is get on their prone position, lying face down, test this, grab their legs, and just traction slightly, and then pull into a little extension. If it immediately starts to reduce their radicular symptoms, starts to calm that muscle spasm, and they kind of let out this, and their arms relax and their face falls into the cradle, you've got a slightly posterior protruding disc, and just hold that. Hold that traction and extension. That's what we call a directional decompression. You're pulling that extension, it's pushing that disc back anterior. They can leave your office within 10 minutes of just a little bit of traction and extension, dropping their pain from 8-9 down to like 3-4. Really simple, really, really simple. And then consider severity. right? Is there significant injury from an acute sprain strain? Are you going to have what we call a secondary hypoxic injury? Again, Dr. Wheeler mentioned this. If they have a lot of inflammation, that inflammation seeds into the other cells, local tissue, and it's going to affect their mitochondrial function, and you're going to affect tissue that's healthy is going to start to die off because they are going to be hypoxic because of that inflammatory cascade from that acute sprain. So you got to take care of that. And then, what's their functional capacity? Can you even treat them? Can you do a physical exam? What sort of treatment do you need in place first? Again, I highlighted modalities, exercise, an acute, simply strengthening and range of motion right away with the range of motion that they have will start to turn their pain around quicker than anything else. Again, you can see that I harp on this a lot. Same thing. Things that I use it for all the time. Acute sprain strain, right? In that low back. They sprain their back. Whiplash, right away. Get them doing some core activation. Just stability, plank holds. Things that they don't have to move for. Get them into a neutral spine position and just get them to strengthen that abdominal wall. Disc herniation, same thing. If they can strengthen and stabilize, it, again, I think I wrote here, it will immediately modulate the cortical pain pathways, the descending pain pathways that inhibit pain, and that increase in proprioception that they get from being able to know what their muscles are doing will also inhibit pain at the spinal cord level. So regardless of where it's coming from, it will inhibit that pain pathway. Acute pharmacotherapy. A couple of notes. NSAIDs can be useful in inflammatory conditions, but they will delay healing and can affect long-term tissue integrity, right? So use them as needed. Acetaminophen doesn't really have a huge role here. It is not recommended as pharmacotherapy for acute low back pain. Limited effectiveness for most of the conditions that we're thinking. NSAIDs are going to be better unless you can't use them. Muscle relaxants can be super useful in acute muscle spasms, severe muscle spasms. But again, caution your patients. Can be sedating. You can get some dizziness depending on which one you're using. Have they used them before? Do they have to go on a big drive? Do they have to be awake for work? Timing of dosing those can be important. And then this one, I wanted to highlight and give you guys a slide on exactly how to dose this. Dr. Wheeler touched on it. Strong non-opioid NSAID. It is super, super effective. It's comparable to basically how they use tramadol in hospital setting. We can use this in our primary care setting, and it can work very, very well. So how to dose? What I wrote is just for a healthy adult. If you have pediatrics, which I don't think you'll be using this for them, or if you have somebody with kidney clearance issues, you got to modify the dosing. But it's a maximum 5-day duration of the therapy, and you can discontinue earlier if they have broken that cycle of severe pain. Start with single IM. You can do IV, but IM dose is 60 milligram single dose, or you can do 30 milligram in divided doses. The daily maximum for IM is 120 milligrams for that first day. But think practicality. Are they going to be at your office for 6 hours for you to separate out the two 30 milligram doses? What severity are you working with? Do you only need one single dose of 30 milligrams and start them off? Or just give them that 60 milligram IM dose and get them going? Prescribe the oral follow-up therapy. Again, oral therapy is only follow-up to injection. This is going to be, what I wrote was 10 milligrams every 4 to 6 hours. So 40 milligrams max per day is your dosing. You can start, again, with your oral therapy that next day if they're still having a significant inflammation, pain, it's minor improvement with that first shot. They can start their first dose at 20 milligrams to get, again, that bolus dose. That's how this medication, we want to get bigger bolus early on because we can't use it long term. Can be super effective, but along with this, you're using this so they can do your other therapies. So you can get them into somebody so they can start treating them with whatever tissue pathology they came in with, right? Whether you're going to start with just contrast hydrotherapy, whether you're going to start with traction, some exercise stuff, acupuncture, whatever it may be. Start treatment as early as possible. Remember, meat.
Do you
Couple.
use it oral doses for 4 days then, or 5 days total after the IM?
So 4 days is ideal. It's considered maximum combined 5 days of therapy. Yeah. So you want to start it the next day. Yeah.
Do you do the IM nearest to this pain, Like if it's shoulder, you do deltoid. If it's low back, you do.
Not necessarily. Just bigger muscle, less burn with it, and then if it's low back, then I just do it right in the ESGs or QL area, right? If that is the muscle that's actually most inflammatory, then it's awesome if you're doing it right there. Yeah.
Do you give any consideration in the IM dose for the size of the patient if you had like a petite 100-pound female versus a larger 200-pound linebacker?
Yeah, if they're this dosing was based on essentially 150 pound healthy adults. So if they're like 110 pounds soaking wet, you drop the dose. Yeah, there is again it has it's a pretty strong NSAID as far as NSAIDs go. So I think most of the time we've used it, we've ended up doing the 60 milligram because most people have been good size, average size.
If they're within 50 pounds, just go with the 60. Yeah.
I'm just checking if you've taken other NSAIDs that day.
And that's not an absolute contraindication unless they took a lot.
Couple of clinical pearls, acute protective muscle spasms. Again, it's generally due to an inherent weakness or an instability combined with an acute trigger. I would say a good 70% of the 80% of the acute pain that I've seen, low back pain that has come in the last year, has been this sort of picture, right? Deal with the acute, get that muscle spasm calmed down, but if they haven't stabilized that joint or that area before, once that muscle spasm is gone, it's just going to come back, right? And it's going to come back worse because now the body's thinking, okay, I let go of that muscle spasm that I built together, to protect your spine, but now it's gone. That wasn't enough, and I'm still unstable. Let's hit it again, right? So you have to stabilize and get them going. Physical therapy, strengthening, movement. Therapeutic order, again, does your intervention match the severity? Super severe, use your medications that you can, use your herbs, use your supplements. And then follow up, right? Manage acutely to the best of your abilities, and then either see them if you do physical medicine or refer them. Get them in early. This is, we're talking about prevention of long-term issues. Acute injuries, you can stop that chronic pain, that process of chronic pain right away if they strengthen and reverse that. Ligaments will heal better than the research says if you actually have some strengthening as a stimulus. That's all. Any questions? I know that was a lot of information, but use those slides, use them as a fallback to kind of compare where your physical exam is sending you, and then what condition you might be working with, and then how to go for treatment. Awesome.
Thank you.
Thanks.